us within the next few minutes. So my name is Miriam Adesokun. I'm the research director for the West African Institute for Applied Health Research, and really glad to be here. I think we had over 130 people register, so really expecting more people. So thank you for making time to attend. Um, I'm showing the agenda right now, but you must have received it via email. But if you didn't, this is what the agenda looks like. This is actually a two-part webinar, and the next one will be on the 12th of November, and we'll do a further deep dive into multimorbidity and the African context, etc., and look at the way forward together with our various members of the panel. So our main objectives for these webinars is really to explore the impact of World Health Organization and the essentials, the World Health Organization essentials medicines lists on multimorbidity care globally, and to examine opportunities for embedding multimorbidity care within World Health Organization's integrated people-centered health services framework across Africa. So today we're starting off the conversation with Dr. Yemi with the first keynote on multimorbidity care and current health systems, with the global focusing on the global evidence gap. And the second keynote would be by Lorenzo Moya, and he will be talking on the World Health Organization essential medicines list in the era of polypharmacy and multimorbidity, and looking at the global perspective. Our third keynote speaker will be Kidist, and she will be talking on when trust isn't enough, improving use and impact of the World Health Organization guidelines. You'll have the opportunity to ask questions towards the end of the webinar as well. But please do write down the questions, and when it's time, you can bring them up as planned. And then we'll look at the way forward and talk a little bit about the next webinar in November. So I'm just going to quickly introduce our keynote speakers. Dr. Yemi Opeyemi Babatunde is the senior lecturer at Keele University. She's an honorary professor of global health at the University of Ibadan, specializing in applied health research and implementation science. Her collaborative work focuses on guideline implementation, musculoskeletal health, multimorbidity, and inclusive research involvement. And we also have Dr. Lorenzo Moya. He's serving as the World Health Organization Secretariat of the Model List of Essentials Medicines, aka EML, as a scientist, and is an internationally renowned researcher who has advised governments of several countries, including those emerging from crisis and conflict, and is also a professor of public health at the University of Milan. Next, we have Kidist Kebede Bartholomeus, the unit head and product design and impact unit at the Department of Quality Assurance, Norms and Standards, Science Division with the World Health Organization as well. Next, we have Karen Gibbs, who's an assistant professor in the undergraduate department at CISIC School of Nursing at the University of Texas Health Science Center at Houston. Her experience covers pediatric multidisciplinary teams in sub-Saharan Africa to develop guidelines for cancer care. And lastly, you have myself. My name is Miriam Mubolade Adeshoko, and I'm the research director for WAFERs, seasoned researcher focused on managing long-term conditions and multimorbidity in low to middle income countries. I'm currently collaborating on the PAM project with the WAFERS team, and that's focusing on the stakeholder mapping, scoping reviews, and developing the PAM consortium. So please join me to welcome Lorenzo to the stage. Opeyemi to the stage to start with the first keynote, and then she'll pass it on to Lorenzo. Thank you.
Thanks, Balade. Really helpful. Just going to share my screen. So, can everyone see my screen okay?
Yes, we can.
Good, good, good. So good afternoon once again, dear colleagues. And again, it's really, really good to have you here. My organizational affiliations are just right there on the slide. Just to say that views that I express today are entirely my own and based on some of the work that we've done and learned over time. I'm going to be giving my talk with a introduction just to set the scene, really. I'm just acting as a forerunner today for Lorenzo and Kiddies, who are really going to be sharing, and panelists when we get to that point of discussion. And I'm really thinking about the fact that how do we do no harm, especially with multimorbidity care? So, we've already talked about our key objectives for today's webinar, which is really to understand the impact of WHO EML on multimorbidity care globally, and to understand how to improve development, use, and impact of clinical guidelines for multimorbidity care with the aid of WHO design principles and tools, and Kidis is going to shed more light on that. We're going to try to examine opportunities. How do we actually embed evidence-informed multimorbidity care within our home country health services, and especially in high burden and low resource contexts, and and we'll be dealing a lot with that at the next webinar. And importantly, we really want to connect with peers and exchange lessons and best practices. I don't want you to wait until the time when we have the interactive discussions. Please feel free to post questions as we go along in the chat box. So yeah, this is supposed to be really, really interactive. So I probably don't need to flog this. For everyone that is on this webinar, you would probably know that multimorbidity is an increasing global health problem. And not one health system is excluded or spared from this. It's growing, and as you can see in on this slide, you can see that well over 1.15 billion people are estimated to be living with multimorbidity globally. And in high-income countries, estimated to be 0.52 billion. And you can see that the burden is really higher in low and middle-income countries, up to 0.87 billion people. And this is just the statistics for people that are 50 years and older. There is increasing evidence that multimorbidity is no longer a problem of the aging. We have more and more young people coming down, having two or more chronic long-term conditions. So it's a really, really important thing. But importantly, I was at a conference, the Jane conference a few weeks ago, and somebody said, "Oh, you're the chair of the multimorbidity working group. That's the guideline nobody wants to talk about." Why is it that nobody wants to talk about it? Because it is quite challenging, especially when the patients come. We have already guidelines for massive amount of conditions very, very separately. But then, how do you develop a guideline that takes care of multiple conditions? And it's not just a particular cluster. There are different clusters, different groups of chronic long-term conditions that a person could be presented with. And that's the challenge that we face at the Jane Multimorbidity Working Group. So the systemic challenges that are associated with multimorbidity is just held here. We know that all our health systems, they are not set up to manage one person with, massive amount of different number of conditions at the same time. What our health system are set up to take care of is single conditions per time. But we also know that is now, increasing the complexity of care, coordination, and is giving rise to a lot of issues when it comes to multimorbidity. One of the issues that we could also think of is how to be efficient in multimorbidity care. Most of our healthcare systems are overburdened, and the health workforce, they are experiencing burnout. That's another strand of issues, that are related to multimorbidity, but not just multimorbidity, it's just globally. But importantly today, we want to look into inadequate medication review and the impact of polypharmacy. We know that multimorbidity, as most people that are living with multimorbidity, they tend to also exhibit polypharmacy practices, either as self-prescribed or even things that are prescribed by their healthcare professionals. So how do we look into some of these things, especially with thinking about the WHO framework? I kind of put this slide up just to kind of share with us what we know to be happening in real life. We do know that there is a lot of guidelines out there, and especially, one of the reasons why we're here today to think about the WHO EML. There is evidence-based recommendations in code, but what is happening in real life does not often reflect what is inside those evidence-based guidelines or recommendations. Why? Because most of those things are usually, some of them sometimes they can be available, but not accessible to some regions or some health systems or some healthcare professionals. But there's also the question of, do people actually understand these evidence-based recommendations, and are they widely accepted? And that moves us to the question of adoption and contextual appropriateness. So you see on the side of this, even though WHO might have their essential medicines list, but look at the way the patterns and behaviors when it comes to medications, how people either get their medication, and also how do they behave towards medication. You can see that when some respondents, especially this particular data was taken from Africa, you can see that preferred place of seeking healthcare, most people would say that they are trying to seek healthcare in healthcare system, they're attending healthcare system. But we also see that the bulk of patients they are actually visiting patient medicine stores. And in patient medicine stores, nobody talks about WHO EML or any guidance whatsoever. And a lot of them also take medications that are self-prescribed and traditional healers, patent medicine dealers, and a lot of things that affect medicine's use is really tied to affordability and accessibility, where they can get it. So in real world, we can see that a lot of people, from data that we have, over 50% of older adults with multimorbidity, they are prescribed potentially with inappropriate medication. And at least 1 in 3 of them are taking over 2 medications that can cause them sedation and confusion. And at least over 60% of them are taking psychotropic medicines that have minimal evidence of benefit and also have increased risk of harm. Now, the data that we also have is also showing that at least 1 in 4 unplanned hospital admissions are as a result of inappropriate medication. And a lot of these are related to multimorbidity. However, guidelines are there to support and limit care that provides no benefit and may even be harmful. We know that rationing in health is inevitable, and arguments about economics of health interventions will always continue. However, in the process of trying to do good, especially with respect to multimorbidity, it looks like a lot of harm is being done currently. The most important benefit of clinical practice guidelines, you would agree with me, is their potential to improve both the quality and or process of care and patient outcomes. So you can see the example from NICE, just they're introducing a guideline on knee arthroscopies. You can see that the surgeries that were done on knee arthroscopies reduced. Thereby, they were trying to save money for the healthcare system and remove low-value care for people with knee pain. The question is, what are we doing to address polypharmacy so that in multimorbidity, so that people actually have high-value care and we can remove low-value care? The role of guidelines is also to yeah, the role of guidelines there is also to, oh, sorry about that. Okay, the role of guidelines is also to, they're crucial for establishing clarity, consistency, and efficiency in various settings. And in the next few slides, I'm going to show you the current multimorbidity guidelines that we have and how they've been, the implications of that for everyday clinical practice. They try to provide a framework for decision making, ensuring their actions align with best practices and desired outcomes. Importantly, we also want multimorbidity guidelines to enhance efficiency and productivity in care. We want them to be able to empower individuals and teams. We want them to be able to facilitate knowledge sharing and learning. Now, this is code from this the data that supports this map that you're looking at is based on a systematic review by one of us in the Gene Multimorbidity group, led by Zijon et al. In 2024. They've done a lot. It's a review of all the multimorbidity guidelines, and then you find that just under 20 guidelines were available for multimorbidity worldwide, and a few of them was addressing polypharmacy, and very, very, very few, even more, address multimorbidity and polypharmacy. In terms of geographical landscape, you can see that most of the places where the burden is really high do not actually have any multimorbidity guidelines to inform practice. So let's look at what is high versus low value care in current multimorbidity guidelines. So we've kind of gone into details to look at, to kind of critically appraise some of the guidelines that we have, the multimorbidity guidelines. And yes, we could probably say that a lot of them borders a lot on effectiveness, on safe care. They want it to be patient-centered, timely care. Equitable care was not often addressed. Connectedness is addressed, but again, and patient-centered care. The three things I probably want to highlight to you is that a lot of the current guidelines, they are not actually addressing cost effectiveness and polypharmacy like we've seen in the previous slide, and also minimization of waste, which means that a lot of care, a lot of treatments, massive amount, when people come with multimorbidity, we want to throw everything that we have at it, which is right. But in the process of throwing everything, all the treatments that we have at it, are we thinking about doing no harm? So the other important thing is about multimorbidity guidelines is about their content, the format, and the language. Like we saw in the earlier slide about the reality versus the evidence recommendations that we have. A lot of these guidelines are very, very still inaccessible to healthcare professionals based on research that has been done. So, do you know harm in multimorbidity care is not really a something for healthcare professionals alone. There's a lot of stakeholders that are involved in this, and I'm really hoping that the people on the call today are from different wide range of life. But even if not, but we need to be reaching out to especially some of the organizations, the policymakers, purchasers and businesses and families and patients even thinking about their um, their their approach to high value care for multimorbidity. And what are we doing as a multimorbidity working group for the Guidelines International Network? We are currently developing a consensus statement, and we will consensus on the core components of multimorbidity care. We're looking at what are the principles and values that needs to shape multimorbidity care, and looking at where there are evidence gaps and primary studies that still needs to be undertaken. Most importantly, at the forefront of this is thinking about under provision versus over provision of care and how to maximize health benefits in the balance of cost. So when we think again about doing no harm, we need to be thinking about rational prescribing for multimorbidity. And some of the things that issues that might need to come up is on the individual level, about the quality of life, the satisfaction, and adverse events, even more importantly, especially in low resource settings where a lot of people self-medicate a lot. And also at population level, we need to be thinking about the societal cost and outcomes. The planetary implications of this is also there. And we also need to be thinking about the scope to prescribe and deep prescribe. Who should be doing it? Where does the responsibility lies for rational prescribing, especially for multimorbidity? And in healthcare systems whereby things are a little bit porous and people get access to medicines, to prescription medicines that they're not supposed to get, to have access to. The other question is really about quality indicators of care for multimorbidity. My talk has raised a lot of more questions than answers, and I'm aware of that. Not that I have answers to all of these things, but that's something for us to all discuss about. But in rounding up, really, I want to round up with a call to action. There are definitely low-hanging fruits when we're thinking about doing no harm in multimorbidity care and the concept of polypharmacy. We as a multimorbidity working group of GENE, we're looking at update of current guidelines. And of course, this is not something that we can do alone, but all other organizations and stakeholders are involved in care really needs to be thinking about this for their own local context. The other thing is the demand and supply of low value care. Health is a very important concept for everyone. And when things are not going right, we just want to do things. We just want to do and do and do. But again, we need to be approaching patients and be thinking about their demand, making them to understand that more is not necessarily better sometimes. Sometimes. So the economic and political drivers of low value care and polypharmacy is also there. Again, when there are, especially in porous systems, the big pharma, that's something else to think about. And also, more importantly, is implementation of guidelines. When we have the WHO EML or we even have multimorbidity guidelines, are these actually being implemented in practice? Or what are the novel ways or the unconventional ways by which we can mobilize and implement evidence-based care for multimorbidity? The other important thing that I thought could help would probably about thinking about coordination of care, because when people go into different clinics, go for diabetes clinic, osteoporosis clinic, hypertension clinic, or probably even they have caregivers who is actually saddled with the responsibility of coordinating care and making sure that the medications that are being taken are correct and the treatments are evidence-based. I'm gonna stop there, but one of this picture is one of the a favorite picture that I've come to love in recent days. In the picture, you will see that there's when there is fire ongoing, some people are trying to put out fires, and some people are onlooking. The question really for us that are concerned with multimorbidity care is, are we bystanders, onlookers, or are we actively fighting fires? Or better still, should we try to be actively stopping fires from starting in the first place? Polypharmacy and multimorbidity, there are fires in a way, for our healthcare system. And I just want to call everyone to action to think about how we could stop these fires instead of fighting the fires, if possible. Thank you very much. I'll hand over to Lorenzo.
Thanks a lot. Miriam, should I start? Thanks a lot. So let me just share my slide. I'll try. So thanks a lot for the invite. It's clearly like a great pleasure to be here with you. I have to say that from time to time I have the opportunity to give talks, presentations about DML, and usually is DML plus another word, right? Is a plus something else. Usually these words are like price, universal coverage, access, human right to medicines, health technology assessment. And this is the first time that I've been involved in reasoning on DML and multimorbidity, right, as the two topics and how they connect. And I think I may be like taking a slightly different path. I think that there is not like a strong connection between DML and multimorbidity. I'll explain more about these, and also like to say that I cannot see multimorbidity as an ubiquitous concept. And so I'll try to talk about there is an interplay between multimorbidity and essential medicines. I'll try to cover like how DML evolved over time and why multimorbidity may be more relevant now than a few decades ago. I'll keep these a line in which DML is not a tool for multimorbidity and polypharmacy, and what better tool we have to deal with multimorbidity. As for Opeyemi, she mentioned, right, is how many like more people in their elderly we have, the complex health challenges ahead of us. And I have to think to mention that is also like a data, like is people in the late stage of life, they are ready to invest more in their health or like in their diseases. So that is also like another important element on the multimorbidity when it comes a part of our life in which our willingness, our attitude to invest is stronger. Definitely this is a part of I would say, the third or fourth stage of our life. Now, going to DML, kind of a quick recap of what it is. It's simply like a tool that is introducing the idea some medicines are more important than others. But there is a very important aspect that is that the list is medicine specific, right? The list is not theoretical, is not really an abstract that it comes, is a pragmatic list that is recommending medicines for certain disease. There is a medicines and there is a clear indication that is associated with the medicines. And when we think about the medicines and the role they have for multimorbidity, here I would say that the list usually invite us to keep one medicines, an antibiotic, like an anticoagulant, anti-diabetic medicines, and the role they have in our healthcare system. So meaning the list is not as specific, right? Is then divided in chapters and then very specific recommendation. And that will be important when I link it to the multimorbidity. The list is growing now. It has more than 500 medicines compared to the basically enough that we have in 1977 when the list was then launched the first time as a tool by member states to guide to improve the healthcare systems. And the new additions, the list came out, the most recent list came out in September, a few additions like the GLP-1, cancer medicines, analogs for diabetes, now the rapid acting, and a few other medicines that got some attention, as the list is a prominent tool for member states and for governments. So usually the additions, of course, the addition is also like the rejection, but mostly the additions is what is catching the attention by the capitals in the different countries. And it's not only because of the clinicians, right, or the clinical side, but it's also because the essential medicine is a concept that is closely connected to the supply chain, the local production, basically the countries investing in their own system to procure medicines. So there is a very close connection, not only on the clinical side, but to the health policy side. The list has evolved over time, and I think this is important because, we also can see multimorbidity as a, if we want, like a more modern concept. And the list, was born as an essential, to consider essential medicines for basic healthcare systems. But then, even in the 17 and the 80s, evolved, right, in being something that expanded more with the support of international agencies, UNICEF, the World Bank, to come to the 2000, let's say from 2000 and on, the list became like a tool that is also including income countries. It's really moving from the basic needs to the priority needs, then to the universal health coverage. And I think with that universal health coverage is where we also start to have some overlaps with multimorbidity in terms of the expansion of the medicines. So we increase the number of medicines that should be made available. We should also increase the number of indications that are covered. And these also includes the multimorbidity. And then we have a late stage that is the local production, but I'm not talking about this today. So it's also important now, if you look about the number of essential medicines in different countries, the map on the left is showing that the countries have very, very important differences in the number of medicines that they have included in their national EML, in their reimbursement listings, and there are many differences across countries and between each country and the model list. This is a kind of fragmentation, but now let's think about where we have more fragmentation and less fragmentation. The blue bar and the orange bar. The blue bar that you see is where we are looking at primary care. The orange bar is where we look to hospital care. Multimorbidity is mostly connected to the hospital care, right? It's mostly where we care about these complex patients, in the internal wards that require an approach that is multidimensional. Where the member states, where the countries are more homogeneous, are more, if you want, harmonic in the way they provide their care, is around primary care. Okay, that is where we built over the past 5 decades, a system that is stronger, right? Well, where we have a lot of differences with several countries that have still to improve the way they provide a care is in hospitals, basically. So that is a space in which we see that somehow is multimorbidity may be a neglected aspect of the care that we provide. And now, like, I think the most important slide that I have for this first presentation is about then DML and if DML is resistant to multimorbidity, which is a question that I'm inclined to say yes. So if you think multimorbidity is a tool, is a concept that mostly deal with the elderly, and DML doesn't have any specific section for aged people, but we do have a list for children. And that is showing us there is a preference, which I think we can agree on investing more like on the first side, right, to the children, right, is ensuring that they have the right to have a long life in a health status. The multimorbidity is often a concept that goes with polypharmacy. And I would say that is the concept then of polypharmacy is in opposition to DML, right? DML is aligned to the medication review to keep limited the number of medicines that we prioritize. So that is also like important. DML doesn't include and never included medicines that may be seen as a part of multimorbidity, as the anti-dementia, the acetylcholinesterase inhibitors, or gabapentin for neuropathic pain, or supplements. This was never like recommended as a part of the model list. In the near future, what is going to happen, right? I think that still DML will be covering both acute and chronic conditions, but acute are like really, really important. So acute is normally not part of the multimorbidity. DML will be continued to privilege the ambulatory over hospital based services, and cancer-related immune diseases may be like a raising, of course, maybe also like is a part of DML in which like there may be some overlaps with multimorbidity, but the fact that DML is insisting on the feasibility ambulatory care is also an important aspect that has implications for multimorbidity. And DML is not a guidelines, right? I think is not a guidelines. It doesn't cover the appropriate prescriptions, the risk of polypharmacies, the drug interactions, and is not a quality improvement tool. So when we look to the ecosystem of decision-making, I think we have different tools, the HTA, the ML, the guidelines, and I think on the multimorbidity guidelines have clearly like a most important role. They are clearly like a prior as compared to the EML. My conclusion, so the EML is clearly a global concept. In that sense, it may have like some overlaps also with multimorbidity, but it's not a basic list, has never been, by the way. It is unlikely to offer unrestricted support to polypharmacies or multimorbidity, right? It's actually like a tool that will be still kind of evaluating the medicines mostly in isolation, okay? Chronic disease treatments, multimorbidity, and polypharmacy as a different concept. I think it's important to acknowledge these. And there may be an exception. I'll be talking more like in 1 month about the GLP-1, because the GLP-1 may be the first medicines that is recommended in the ML that has a lot to do with multimorbidity. And the prohibitive prices that we are seeing are associated with the type of disease rather than multimorbidity per se. Thanks a lot for your attention.
So Denise is going to take us on a next short presentation, and then we go into discussions afterwards.
Can you hear me?
Yes.
Fortunately, for some reason, my video, every time I turn it, I can't, just don't get the picture, just get white screen. So I'm very sorry. For the discussion section, I'll switch to my phone so that actually we'll be able to. So I'm going to try to share my screen, and then let me know if you can just see it. You see it?
Yes.
Okay, so I'm just gonna try to do oops, sorry, to do on, did I move? Okay, great. Thank you. Okay, thank you very much for the invitation and for this session. I'm very happy to be joining you in this session. Yes, and when you invited me to be part of this work, of course, to share on the WHO design principles and tools, and I went back just to think a little bit back to my work. My background is on injury epidemiology, and remember a lot of the work around falls and in the elderly, which is very much a lot of data around falls, especially the elderly, the risk of falls in older adults, and mostly from multimorbidity, from other things. From one study I was looking at, from loss of balance or muscles or other types of long chronic diseases being the risk factors for falls. And so it's just kind of some background interest that I saw that the public health implications are even more broad, even from what, and the importance of this presentation. So what I will be speaking about, is my screen moving? No. Yes. So the title for my presentation, again, when trust is not enough, improving the use and uptake of WHO's the development of the guidelines, but with specific focus for this topic. And just as a note, this is based on a presentation that was done, adapted from a presentation we did from the GIN conference. And I wanted just to acknowledge also some of the people who've worked with us and the designers, mostly the experts that we were engaging with Monash University, led by Professor Heiss, and then and her team, and from WHO also from my colleague Elisabetta and the team from the former PDI unit. For this session, what I will be trying to do is just give you a little bit of background, why we think this is important, just trying to situate the discussion for us, and focusing why we have to do these guideline principles, the challenges and barriers to uptake, and then what was the challenge that we're trying to address with this, and then give you a little bit about the development, because this is really important, how is inclusive, especially for the follow-up discussions, and then just share with you a little bit the principles, and then maybe open up. It's more really to open up. The main objective for me is what I think would be the best use of the time from this session is in the future of clinical guideline design development for multimorbidity care with this. If we can just have a little bit of time discussion as opportunity applying these principles and tools. To move this thing where I don't need to tell to GIN members or others who are joining this that WHO guidelines our trust is not an issue. They're a trusted source of health service advice for nations in low resource settings. WHO issues these guidelines for WHO, as just Lorenzo just really eloquently presented all the different type of tools that are available, but still we know that their uptake and implementation is a big issue and remains slow in more low middle income countries. And we're trying to understand this. There was studies that we have developed when WHO during the transformation, when this new department was established. We looked at if we're going to improve impact in what are the challenges. And from that study, we were able to identify, these were from focus groups that were done, even other scoping reviews, and just a mixed method studies and different sources. We were able, if we have to group them, it could be grouped into two types of the health system related issues. I think Yemi, you've presented quite eloquently again for this work, for your work. The infrastructure, governance, capacity issues, but actually the products, the way we put them out, the way we design them in the first place for communication dissemination, themselves have some issues. These are some quotations and things that we were able to pick up from some of the focus groups, the content how it's developed, and the explicit guidance and the lack of some policy coherence, because I think you gave also similar examples earlier, Yemi, how they all for vertical programs and very much, but how it becomes very complicated when it gets into the country. Again, this is just another way of around leadership, governance, the policy coherence, which can apply for this multimorbidity issue as well, because what's recommended in one guideline might be a little different. The other one, the application might be, where do you see them, the expertise needed for what is in the recommendations. It doesn't mean that expertise don't get in the country at the moment, but is it the experience is there, the training available, again, for what is recommended, to the enough the infrastructure and resources there, and funding, which is the usual. So in short, around these issues, the leadership, the funding, lack of, but at the same time, this content and the format itself of what is actually a problem. And we thought that was one of the things that we can actually address at the design stage, and what can be done. So the principles work. Again, is what led us to doing these principles. So just give you a little background how it was developed. It was over 2.5 years to support these developers. The research team engaged in these consultation co-design processes to develop these things. The work involved 4 global consultations that brought together these people from 15 countries. And then in the first workshop, sorry, I'm just trying to move. It's okay. And the first workshop, brought about 33 participants from 8 countries, and this was done online to discuss how the guidelines can be redesigned if we want to make them accessible to people and communities. And at this time, we were looking at a mortality surveillance guideline, specifically for external causes that WHO issued in 2012. And we used those to really understand, the different people who are using it. So to anchor the discussions, it used scenarios in setting up the surveillance system. For example, we took the example of United Republic of Tanzania, and if we developed these 4 personas and the users, and then design tools on the consultation were then co-created with other clinicians who are in the room, and to participants to ensure the accuracy. And these are, the different, Helma is like the program officer, the statistician, the program manager, and the forensic pathologist, and then to say, what would be the challenges, and then use that information. This was working small groups that were guided through a number of activities, really to unpack to understand the guideline users, accessing them, the evidence needed. And this was distilled, and by that time we came up about 7 from the first workshop, and from the creation of these 7 prototype principles. They were tested, and again in another second workshop consultation, then we brought another 22 people from 5 countries, and this was held in Geneva, and again to test these prototypes. This time, a GRC approved guideline. The other one was just a surveillance type of guideline. This was a tuberculosis guideline. We brought together and said, can we just think of actually the different people who sit around the table and actually develop guidelines? Can we have a good understanding and develop these personas? Not everybody have an understanding of these when they sit together to develop them. Then the workshop again used these personas and involved these are the people just sitting around to develop the scenarios and the things. Participants have said then how these could be applied for real world practices and work routines through lenses of personas and reprototyping. Finally, the final workshop brought again another accessibility, clarity, and translation people, experts from within the WHO publishing process. And this workshop focused on developing, evaluating the tools. This image just shows you the participants engaging in these development processes, and the tools that then were prototyped, examination, accessibility. Finally, the things were launched in 2024 across the globally, but currently accessible for WHO internal things. So the first principle is design with empathy, and authors, sorry, here. How do you minimize this thing? I'll just put it here. This should be developed. So principle one, there are 5 principles. Design with empathy, understanding. Authors and designers of any guidelines should develop understanding of the individuals and the groups implementing a given guideline in the unique circumstances and requirements for implementation. Second one was the second principle is design for living guidelines. And this is something you hear about a lot to address the update issues. But at the same time, in WHO guidelines and trusted documents, if they follow this living approach, we think that they will strengthen this foundation with communities and where these guidelines will be implemented. Third, accessibility. These guidelines need to be developed inclusive of all people who use them. Every effort should be made to eliminate any barrier to their access. Clarity, this is a big issue, especially if you're going to be, as they need to be translated. Authors of WHO guidelines should write with clarity to the consistent structure and be as concise as possible. 5, design for translation from multiple languages and should be written with translation in mind. International audiences bring with them a diversity of language, culture, identities, approaches to health and healthcare. So these are some of the tools that were developed. The first for support interdisciplinary, sorry. So, just 1 second. That's the thing we need. Sorry about that. Yeah, for support in this interdisciplinary development and users' needs, stakeholder. And all these tools have been used currently with the WHO WASH guidelines, which was also presented at the GIN. And currently this copy is available and accessible on the main WHO website. In conclusion, designing with empathy, living and accessibility, clarity, these 5 things have a potential to improve the uptake and implementation of the clinical guidelines for the morbidity care. And these evidence tools can support implementation, their design principles, and it really requires co-designing with stakeholders, understanding end user needs in local settings. And for that, we need to understand both the users and the developers' needs are really equally important. Accessibility and clarity, especially in this age, where as we're moving into machines, AI, and other automation, and this becomes even more critical to address the misinformation, how these needs to be addressed both at macro, understanding the factors and actors, and macro level, the fonts layout. You'd think these are very minor things, but absolutely are been shown to be really great barriers for uptake. Some of the important and time-consuming guideline developed and are currently out there. So for discussion, what I wanted to put out later is in the future, as you're envisioning this future of your clinical guideline design for multimorbidity care, what opportunities do you see for applying these principles and tools, or even development of new tools for some of these principles? Thank you again for the opportunity. I'm done. Thank you.
Great. Thank you so much. So hi, this is Karen Gibbs. Thank you so much for your patience. Also for, I had some technical challenges joining. But I know that we wanted to take a little bit of a break after our keynote. So I was going to let everyone take a little bit of a break before we start into our panel discussion, where I've got a couple of questions and we can punt that to the panel for everyone. So yeah, we'll take just a short little break and then we'll start the discussion with everyone here. So just, I think we've got 3 more minutes. All right. So hopefully that was enough time for everyone to grab a cup of tea or some refreshments. But I was going to go ahead and invite any questions or comments to the chat box for anyone who would like to ask questions for our panelists. I have a couple to get us kicked off. So I wanted to start us off with, I noticed that in all of the presentations, which were absolutely fabulous, I think that one of the common themes that came up was clearly with multimorbidity, we have you know, a very complex problem, and this often requires complex solutions. I know that in this, you know, we have not only this coordination of care challenge, but polypharmacy, and not only that, but making any sort of guideline and the primary research and its application. We have some implementation challenges as well that all of our panelists really eloquently highlighted. And so I know that as far as one of these you know, facets of complexity that was discussed was on deprescribing from a polypharmacy perspective, which I think touches on you know, what each person discussed a little bit of for de-implementation of some of those low value practices, and then the communication strategies and implementation strategies of these, and how that was kind of aligned with both what the, you know, the concept of the EML, and so I was wondering if each of the speakers could start us off with that concept of de-implementation, and with respect to folks who experience multimorbidity or complex care, and where do you think we should prioritize and move forward as far as next steps, knowing that this is a very complex problem? And then I'll pass it over to Yemi to get us started.
interesting. Well, it's interesting to see that the WHO itself does not currently have a multimorbidity guideline. They do have like a big policy document, which I'm not standing here to criticize, but which if we put it with the KIDI's design principles and tools, I'm not sure if it would probably align, but I also understand that these design principles and tools were just recently developed. But I'm just thinking one of the ways that we can move forward on this point is to, first of all, develop a WHO multimorbidity guideline would be a good thing. But on the side of that, of course, that aligns with all the principles that KIDI's has kindly shared with us. But on top of that, I think it's also more important that we move into the community and have patient version multimorbidity guideline, because I think if until we address the demand side of things for low value care, we will not be able to reduce polypharmacy or address it in its entirety, because it's not just clinicians that are responsible for polypharmacy within multimorbidity. So those two things I'm really thinking, a clinical practice guidelines for healthcare professionals and a patient version guidelines that is accessible, meet all of those design principles that KIDI's has shared, would really help a lot to address those low value care.
Yeah, thank you. And Lorenzo, going to you. So I know that you mentioned about how the concept of the EML and polypharmacy are kind of, in contrast with each other. And then you discussed a little bit about how the multimorbidity is often linked to hospital care. And I know that the idea, hopefully, is that the management of multimorbidity could hopefully keep folks out of that hospital in the tertiary and quaternary care arena, and that there was no EML targeted for the elderly as a population. Did you have any other thoughts to add on that that kind of concept for de-implementation for polypharmacy?
I can try to make an example to clarify, is how like a multimorbidity and EML overlap in terms of cases. So if you think about a 70 years old patient that has arthritis, chronic condition, right? Is arthritis or in and out with the poussée of the disease, and then has atrial fibrillation. Again, part of life, right, is with aging. Many of us will get atrial fibrillation, chronic, and then you have pneumonia, basically. You can be cured like at home, you can be at the hospital. It would be a case of multimorbidity, 70-year-old. Is a kind of multi-pharmacy? Well, probably yes, because there could be several medicines involved. It would be mostly, I would say, essential medicines, right? Is a case of multimorbidity. Now we make another example. 50 years old patients with early breast cancer. Okay, so is early diagnosis, correctly, right? But the patient has also diabetes, right? Like in the early is an early cancer, so life is hopefully still longer, has a urinary tract infection, right? Again, like then something that is acute. Cancer is in between acute and chronic. Diabetes is clearly chronic. These are two cases to show, like one is 50 years old, the other 70 years old. What the guidelines or like a DML would have in common for these two patients? Clearly, we hope that there is the opportunity to get access to an healthcare system that provides the care with some continuity across the different diseases, but guidelines would not be in common, would be different type of patients. EML would not be in common. There would, apart potentially, there may be like some antibiotic in the acute phase that may be overlapping, but it's not even the case. The rest is different. And I think there is a so like is when we tend to collapse into multimorbidity or like with chronic diseases, two different concepts and healthcare that is different and that will require still to make much more specific recommendations, being both linked to the EML or the guidelines. With the polypharmacy is when we go on I would say, on a common background, because there is a tendency by both, I would say, the guidelines, the EML, and potentially other decision-making tools like a WISE list and so on, to diminish or decrease the number of options that are offered to the patients. Thanks.
Yeah, thanks. I think, from my perspective, so I work in pediatrics, I'm a pediatric nurse. I know that one of the other facets we see is, children who have diseases like cystic fibrosis, which we now have not cures for, but, I even have a friend from my childhood who was told that she would, die at 25, and now she's my age. She's like, I wasn't planning on living this long, and then the complexity that comes with those kinds of things. Same thing with, congenital heart defects and all sorts of other components that now they have that other added layer of complexity. And I know you mentioned novel agents and like, how are we adjusting the list? And like you mentioned, it's a tool by which we use to implement from the EML perspective. But yeah, it's really
Karen, again, what you are mentioning, I think, is a clear example that goes against multimorbidity, meaning Ivacaftor and then the treatment for cystic fibrosis are taking out from multimorbidity, are not adding. If you take early on, then these medicines, as you're saying, you basically would not experience a lot of sequelae, consequences that would have led your life into multimorbidity.
But then they can also have just the regular, aging related complication, and then or other things that, so as an example.
Yeah, with age, we're assumed to get more diseases, right? Still,
right. And then there's no primary research to support from a guideline perspective on how do you treat with some of these, to support, like, how as a clinician would you support the care. So it's kind of like the wild west, as we say. And then the coordination of care with the specialists over long term is another added challenge, I think. And how do we prioritize it in the lots of priorities in the grand scheme of things. So it's a challenge, I think, overall. But yeah, hopefully, there are a lot of examples where we hopefully can in the future get rid of a lot of the bigger problems that but yeah, I think a really fascinating future, lots of fun for us. And then Kittist, I know that both you and Yemi had mentioned about the importance of engaging and the inclusiveness portion of engaging the interest holders. And meaning both the users of guidelines and then and if you can speak a little bit more of that and the importance of that, and like you had mentioned, even the small changes can make a big difference. And I was wondering if you can just take a little bit of time to expand on that. And then I see we have one question, and if you can, if y'all feel free to put in more, please.
I switched to my phone because my camera isn't working and I wanted to see everybody, and then people want to see me. Yeah, it's a challenge. You know, it requires a really big mindset change. And the way when I work in this design work, coming after 15 years working in the injury prevention field, where we've taken, you know, that example, if you give the 50-year-old and 70-year-old who came and with more multimorbidity, but if they fall, it's different. We deal with the fall and we say, oh, this falls, but they have, you know, so how do we frame it from the injury field? We frame it, they say there is enough evidence on injuries that those with multiple morbidity should be targeted for fall. Again, it's on the focus is on the disease or on the product or the thing. Can we make it about the person? So what that means is not individual. When we say person is, if it is for the low middle income countries, if you're writing a guideline for a low middle income country or needs to be adapted for, no, I'm not writing for just low middle. You take the evidence, we have the grade, we do all that. But then when it needs to be contextualized, needs to be looked into, that is where the even more, you know, the documentation there is where you see the systems. So if the users and the patients, the individual, it is targeted for that, how you would package it, how it disseminate it, and it is for that setting. So it doesn't all have to be done at global level, and clinicians in the countries, they can be engaged, but it's a complete mindset. What is the change we really, really would like to see? So the complexity, so design gives us those opportunities. Really, I want everybody to think about those 5. It's not saying that current design process doesn't do that. It does that as part of the grade criteria. Think about, you know, acceptability, usability, and all those things. But this is a little bit more. When you're designing the product, you're developing to share. So guideline as a product, as a dissemination tool, as a communication, or as a policy tool, or whatever it is. So that's what I mean. And this gives it a really an excellent opportunity because the case can be made. It's not sustainable like this. So happy to continue engaging. And I think those 5 principles are simple enough. And not everybody speaks English. So if you're thinking your material to be, if you're writing it for translation, we have clear examples. All of these things we have done a little bit of research on each of them. So thank you so much. I hope that's a little bit of insight and just excited to work together. Thanks.
Yeah, that's fantastic. And then we've got some great questions. We have Tope, and let's see, we've got, it's interesting to state that one of the key highlights of the panel discussion for the launch in Berlin was the lack of WHO unifying framework. Specifically, MDGs and SDGs have targets for different disease, but none caters to multimorbidity, even though some of the conditions occur concurrently and are linked. So considering that the GBD does not have data on multimorbidity, how do we move these tools into the 21st century? Any initial responses to that one?
Just say something, not about the unified frameworks and all that, but the data systems that are out there, the systems that recommended, because I also worked on a lot on surveillance work, allow us for us to be able, the cause of death form tells you, you know, underlying cause, and then so the data is there. So maybe from, you know, that would be a good place to start. And the research itself is fragmented equally, because if you do a search on multimorbidity, or depending which topic and this, it gives you different perspectives. So having that unifying framework for research priorities, all those would be very useful. But just that's me, just from people analyzing the problem. Thank you.
Yeah, great, thanks. Anyone else want to chime in on that question?
I was going to mention, in addition to that, the importance of, I think, primary research, especially when it comes to low to middle income countries. So some of the work that we've been doing as part of the PAM project with WAFERs has shown that actually there's not a lot of data when it comes to individual countries, for example, within Africa, or maybe we don't have all the data that's needed. So I think, making efforts towards having more primary research around understanding the significance of the burden and working with key stakeholders. So we've been doing a lot of stakeholder mapping, understanding what that looks like for different countries within low to middle income would really be important. That's my take.
Yes, thank you so much, Miriam. I think that's an excellent, excellent point. All right. Let's see. Kudos to, I see some in the comments, some of the kudos to the speakers as well. And then let's see. Yeah, there's some discussion here about the multimorbidity and polypharmacy, and then the number of diseases for multimorbidity may not be sufficient to address the issue for the severity and impact of diseases, and that polypharmacy is sometimes needed for patients. And then I think it is a challenge sometimes to determine whether it's appropriate or inappropriate, and I know that can be quite a challenge. And then Dr. Gul from University of Kiel asks if any of the speakers or panelists can say something about the political and social fabric can impact multimorbidity, specifically in low and middle income countries. Having worked with WHO as a consultant in the field, he's encountered some harsh realities. That's an excellent question. Anyone want to chime in on and give some insight on that?
I'll just quickly say something. I really feel you, Cole, and I think it's challenging. And one of the discussions we had earlier was the fact that, or something that I mentioned earlier was that the WHO itself currently do not have any multimorbidity guideline. I think we need the leadership in that space. You really touch something close to my heart about harsh realities in low and middle income countries. And when I was presenting to look at the evidence landscape for all the multimorbidity guidelines globally, there is not much happening in low and middle income countries. So those are things, but I would let Morenza speak to what WHO can do to address some of those things, or probably what we can do to support or come alongside WHO to get this into reality.
Well, yeah. Thanks. I mean, the social fabric, right, is a clearly an interesting concept, but I'm not sure like the WHO has really the capacity to somehow, right, is solving the tensions around what is coming over the next, let's say, 10 years, 20 years around the social fabric. Meaning, with social fabric, I think that we are meaning the pressure that it comes to the markets in terms of medicines, to expand the market, to find also very often easy solutions. I think the supplements here also with multimorbidity are like an example. You want to go to the pharmacy, you want to buy like a supplement that will solve your health, will solve your multimorbidity. Like that is the type of pressure that we will be seeing, right? And clearly there is a tendency to be very emphatic on holistic approaches, healthcare system that can manage like a very, very complex care with different level of severity. I would say we need to scale down, because in any healthcare system, we can clearly like improve, but we need to remove that social pressure, right? Is sometimes we need to say that is the healthcare systems may be like a more manageable, working in silos. So the multimorbidity should be then divided just to become functional, because otherwise, we will like add like a level of complexity that it will not be easily solvable or maybe costing much more, right? So then is navigating these social fabric and then finding like solutions that have a lot of like that have feasibility, meaning for instance that in multimorbidity we take care of severe cases. The mild to moderate cases, which is like a giant number of people, they may not have the same priority of those that have severe multimorbidities. We need to try to have like a framework to divide also the different types of multimorbidities that we will face in. Thanks.
Thank you. I just wanted to quickly address Catherine's point on coordination of care. So just to assure you, that's one of the components of the essential components of a future multimorbidity guideline that we're trying to put together. We need to be addressing that who should actually take responsibility for coordinating care amongst different specialisms for people with multimorbidity. So that should probably speed us up to do our consensus statement and publish that at some point in future. And I'm aware that we're running past, we're just on time to finish. And then we'll just call Miriam to do a wrap up and closing for us.
So sorry, struggling to unmute. So thank you so much. A big thank you to our panelists and everyone that has attended and asked questions, contributed in one way or the other. We're hopeful that the webinar has at least helped to maybe clarify some things and also giving us all a lot of food for thought. We've raised a lot of questions here that we might not be able to answer. There's a webinar feedback poll that's already showing up, so please complete those. And also, again, to mention that we do have the next webinar planned for the 12th of November. And the next one will build on the conversations that we've had today. And we're hoping that it would be a lot more interactive and help us to develop a sort of conceptual roadmap for high value care for multimorbidity in Africa. So I hope you won't miss it, and I hope you invite your colleagues as well to help us to have a really balanced conversation and bring along questions as well. So thank you all for making time, and again, wish you all a great rest of the week and the month, and look forward to seeing you at the next webinar. Thank you, Lorenzo. Thank you, Kidis.
Thanks a lot.
We're really grateful to have you. Thank you, Karen. Thank you, Dr. Yemi, as well. And to all the teams that has made this possible, we're really grateful. Thank you.
Thank you.
Take care. Take
Thanks a
care,
lot.
everyone.
Thanks a lot again.
Bye, everyone.
Have a nice afternoon.
Thank you.
Bye.
Bye.